When women think about midlife changes, we often focus on the symptoms: hot flashes, brain fog, sleep loss. But underneath all of that is one powerful hormone quietly declining: estrogen. Estrogen affects far more than mood or temperature. It influences heart, brain, bone, skin, and sexual health. Estrogen can be a vital part of healthy living through menopause and beyond. In this episode, we're joined by OBGYN Dr. Christopher Morris to talk about what estrogen really does in the body, what happens when it drops, and how thoughtful hormone replacement can help women maintain health at menopause and beyond. Welcome to Queen City Skin, the podcast where skincare meets science and confidence is always in style. I'm Dr. Elizabeth Rostan, board-certified dermatologist and founder of Charlotte Skin and Laser.
And I'm Dr. Emily McLean, a board-certified medical dermatologist at Charlotte Skin and Laser. We're here to cut through the noise, from social media myths to marketing hype, and bring you clear, evidence-based advice on caring for your skin at every stage of life.
Whether you're looking for everyday skincare essentials, the truth behind trending treatments, or lifestyle tips to age gracefully, you'll find it here.
Because healthy, beautiful skin isn't about perfection. It's about feeling confident and healthy.
Let's get started. I've known Dr. Morris almost since I came to town, and I just dearly love him. I think you listeners are going to get a lot out of this, but let me tell you a little bit about Dr. Morris. Dr. Morris began his academic journey as a student athlete at the University of North Carolina on a swimming and diving scholarship. In fact, he was an ACC conference diving finalist 3 out of 4 years. I mean, big wow. Now I'm going to ask him to show me a dive.
Just don't ask me to put on a Speedo.
Oh, come on. At UNC, he earned a Bachelor of Science in Business Administration, then continued at UNC for medical school. This is where he and I are similar, both UNC undergrad and medical school. And at medical school, he received the James Bell Bullitt Award for Outstanding Achievement. He completed an OBGYN residency at the University of Alabama. I'm going to say Roll Tide, but it's really in Birmingham, but Roll Tide.
It is the medical school at the University of Alabama.
It is, Roll Tide. But let's talk about his career a little bit. He's made significant strides in women's health throughout his career, initially focusing on enhancing prenatal care and collaborating with certified nurse wives and obstetricians to develop patient-centered collaborative models of care. His dedication soon expanded into an area that's been historically overlooked: menopause. And I can tell you, for years, I've sent women to Dr. Morris. I say, just go talk to Dr. Morris about this. I think it's important for your health. Go talk to Dr. Morris. And in fact, in 2017, he became a certified menopause provider through the Menopause Society. He's particularly passionate about supporting cancer survivors, addressing the unique sexual health and quality of life concerns that these cancer survivors encounter. And this is an area often overlooked. It's just like I treat hair in cancer survivors. I think this is really glowing praise of Dr. Morris. And we are not only blessed to have him here in Charlotte, we are blessed, and I am honored to have him as our guest today. Welcome, Dr. Christopher Morris.
Can I say thank you for the
accolades? They're your accolades, dear.
I'd like to end it here. That was
He's going to end his career now. He's made it all. Thankfully, he continues to bring passion to his field.
Yeah, so this is, I'm right off the heels of the Menopause Society meeting, which this meeting I've been to, I went to my first meeting in 2002, which was 6 weeks after the Women's Health Initiative study was released. So I thought, I'm going to go learn about menopause, and I happened to be there at the moment in time when
2002,
right? 2002,
wow.
Arguments, yelling. it was, I thought, what have I wandered into? So so it's been great to be a part of that for all these years. And it's amazing to see what's happened. The last 2 years, the Menopause Society meeting has sold out.
Wow.
They have, with months before the meeting. So that's the interest. That's
amazing.
The newfound interest. And the list of certified menopause providers now women have a selection of choices in Charlotte, which is fantastic.
It is fantastic.
And I'm off to the Cancer Sex Network meeting tomorrow. So
it's Cancer Sex Network,
Yeah.
not just Sex Network.
So there's
Just let's get that clear, listeners.
So this is a group, kind of an offshoot of the Women's Sexual Health Society called ISHWISH, that really focuses on taking care of these women. It's a chance to bring together surgeons and oncologists, gynecologists, and pelvic floor physical therapists, all the people who are trying to surround these patients.
I think I'm getting an idea for another podcast. Well, since you brought up that 2002 meeting, let's just start off with the $1 million question. Does estrogen cause breast cancer?
I mean, this has been the burning question. So if you go back to 2002, the Women's Health Initiative is maybe some of the most misunderstood data. I mean, something that has stuck around for so long. And we often say people, I think, have now learned and start to say, oh, it was a terrible study. I heard it was wrong. The Women's Health Initiative is a treasure trove of fantastic data. But what happened in 2002 was the amplification of one finding, which was barely a finding, and it changed women's health for decades.
2002, listeners.
Yeah,
and it's been until just in the last few years that there's been a big change in attitude.
Yeah, I think patients were changing. There was women in the early 2000s and around 2010 who still felt this fear from all that happened in 2002. And to be clear, that finding, the entire study was not a study on menopausal symptoms. It was not a study for breast cancer. It was a heart disease study. This was one finding, and it was that finding that they had a press conference on. The physicians who were a part of the study didn't have the opportunity to review the data before it was released.
Prior to publication, correct?
Correct.
Yeah.
So, and there's been a great history now that's been written about this, and for anyone who's interested, the book Estrogen Matters by Avram Blooming really documents all that happened, and he himself is an oncologist, so he's a great point of view. He's one of I think we stand on many powerful shoulders that have brought us to this point, and he's definitely one of them.
Totally agree. And I read that book years ago, and I reread it actually, and at the recommendation of Dr. Morris. And any of my patients that are listening, it's probably a book I've recommended to them. So
he's a lovely man, but he is fierce. He's a tiny little doctor, but he's done podcasts. I just heard him on a Kelly Casperson podcast. Mm-hmm. If you've never heard him speak and the passion which he brings to this, his passion for changing healthcare for women is amazing. And he's spent his whole career treating breast cancer. That's his specialty. Mm-hmm. But he is anchored in this idea that this concept of shared decision making is what we call it now. Uh-huh. That this is no longer the doctor says, the patient does. This is a conversation.
And I love that. I love the idea that cancer physicians take care of the patient as a whole. And that's how I've gotten passionate about treating hair loss. They're literally creating bald women sometimes. Mm-hmm. And then just saying, well, you're cured, but this is a 32-year-old woman who's in menopause and has no hair, looks like a man. So a lot of issues, but I think we've dispelled the myth that estrogen causes breast cancer. But is that still out there?
I think it still exists. And I would take, I think that is such an oversimplification. There's so many things that have a correlation with breast cancer, but aren't causative. And mm-hmm. It's, no one sits around the table with a glass of wine and says, that wine causes breast cancer, but how much wine you drink correlates with your risk of breast cancer. So there's lots of things that have a correlation that are not causative. And there's just no question. There's too much evidence that it would make no sense that estrogen causes a normal cell to turn into a cancer cell. And in fact, if you look, the most high-risk time for a woman is in the decade after she loses her estrogen. So you would
no
expect
estrogen there.
Yeah, you would expect women to go through menopause and the risk of breast cancer to go down, but in fact, it does the opposite. It goes up.
That's a very good point, listeners, and I'll just say it again for emphasis. What he's saying is, at a time when women have lost their estrogen post-menopause, that time after menopause, we actually see increasing rates
right.
of breast cancer in the absence of estrogen. It's a very good point, but it gets really confusing. And anytime that C word comes up, it's just overwhelming emotional for women.
The real change began to happen in the early kind of 2020, 2021. And in 2023, there was an article in the New York Times Magazine by a woman named Susan Dominus. It's an amazing article. It's entitled When Women Have Been Lied to About Hormone Therapy.
Bet it made some women angry, didn't it?
Oh, I mean, it called out so much of the hypocrisy around this. And it started a fire. She actually spoke at the menopause meeting that year as an honored speaker. And that article is amazing. And the women who were interviewed in that article, who were in leadership in women's health, really anchored this idea that you don't have to feel this way. You need to have a discussion with someone who understands the literature, who understands hormone therapy, and go through those options. So when people come to my office, I'm not looking to get them on hormone therapy. I'm looking to educate them and help them understand what their choices are so they don't come back later and say, no one told me this. Nobody told me I had to feel this way.
I hear that, and I'm a dermatologist. Well, let's just start with some definitions for our audience.
Sure.
I'm quite certain we have a very sophisticated audience, but let's just break it down. What is hormone replacement and what is estrogen replacement? You hear HRT, and then you'll hear this ERT, and what does that refer to?
We've set this arbitrary time that 1 year after the last menstrual cycle is when you're determined to be in menopause. And that is entirely arbitrary. It's not how the ovaries work. It's not that you're just running along one day and your periods stop. And I think, now that we've given so much more attention to menopause, we've now realized how little attention we've given to perimenopause. And the hardest patients I see are in the midst of their perimenopausal transition, which means their ovaries are declining in function. They're starting to have very irregular hormone production, and their estrogen is all over the place. And that is the hardest time to navigate, both from a hormone therapy standpoint, and I think for many women, it is really the hardest part of the transition.
Yeah, so that's the roller coaster.
That's the role. So
yeah, good estrogen, plummet, skyrocket,
up and down.
plummet.
So I'd say the vast majority of estrogen that a woman has in her body is coming from the eggs and follicles at the ovary. And there's no question that your eggs and follicles are best in your late teens and early 20s. That is when every month the ovary releases, let's call it a batch of eggs and follicles. And it's from those eggs and follicles that her estrogen is made. And they are humming in her 20s. They are I call it a perfectly tuned orchestra. They're doing everything in response to the hormone request from the brain. And as she gets into her 30s and then into her 40s, she no longer has the same quality of eggs and follicles than she had.
She's gone from a smooth, hot sportsmobile to a little age under the hood.
She was the New York Philharmonic, and now she's a middle school band.
Oh dear, I've got the visual with that.
And the brain is still leading the orchestra and expecting those hormones to respond. And when the ovary and the eggs and follicles are not responding, the brain turns up the heat, and it recruits more and more of these eggs and follicles. So the estrogen begins to skyrocket. And then the brain says, put on the brakes, and the estrogen plummets, and it's volume breaks. And so we'll see women who have an estrogen level, normally it would peak at 400 or 450 picograms per mil, and it will go up to 1,000 or 1,200 or 1,400. I mean, they hit these amazingly high levels.
Yeah, so if that's happening to an older woman, a woman approaching menopause, that's not exactly a cause célèbre, is it?
No, it is.
It's not a woohoo, I'm an overachiever.
Yeah, no, it is. That is, the person who says, my periods were regular, I felt fine, I knew what happened in the days before my cycle. Maybe I felt different or my moods were different. I was tired, headaches. I mean, all the things that they had been accustomed to. And now they're 1 week past their period and they have all the PMS symptoms and they feel awful and their breasts hurt. And then 2 days later, they're bleeding right in the middle of their cycle. And that is classic perimenopausal change. That's ovulation on top of ovulation. And it comes from the brain trying to regulate this ovarian function, but it cannot figure out why those follicles are not making estrogen the right way. And then eventually, she's reaching the end of the time that she has eggs and follicles that can actually produce hormone, and those levels begin to stay lower. And she's getting closer to the point where her periods are getting less regular. And this is the person who may go 3 or 4 months and then have a cycle. She's really, what I'd say, in the later perimenopausal phase, and then eventually her cycles will stop.
Great.
So I've just described kind of the range of perimenopause, and once she has gone this prolonged period with no period at all, she's now determined to be postmenopausal. But it's getting harder because some have had a hysterectomy, some have a Mirena IUD, a progestin IUD, and they don't have cycles at all. So this takes some figuring out. Sometimes it takes hormone levels, but not always, just to guide you in what's going on.
Yeah. You've told us about estrogen. That was a very good description, listeners, of estrogen, and it actually improves my understanding of it. I am a physician, even though I'm a dermatologist, but it really helps my understanding of what's going on because it can really be a trap. I'm well beyond that. But when you get your estrogen back and you're like, woohoo, I'm 600, Yeah, and what Dr. Morris is telling us, that's not necessarily a good thing. It means perhaps your estrogen levels are in trouble and your brain is just burning through the gas. It's kind of like trying to learn to drive a stick and you just floor it. Wow, well, you just burned up all this gas and you didn't need to.
It's a really hard time to navigate, and this can begin. I mean, this is what has not been appreciated in the past. That decline in function may happen in her early 40s or mid 40s, and she's really been brushed off how bad she's feeling.
Oh, absolutely.
And
your estrogen level is not zero. Yeah, come see me in 2 or 3 years.
Right, that's right. You're not menopausal yet, or you're
Correct.
Too early. I mean, all those things have been...
What you worried about? You're at 1,000.
Right.
Right. So you do need a thoughtful physician.
Or being told it's normal.
Correct.
And I think sometimes just explaining this is what's happening. I mean, I'm so nerdy. I have a whiteboard in my office, and just to walk through the physiology, and you can just see on her face, like, I get it. Like, that's exactly what I've been feeling, just to understand what's happening. And she may not choose to manage this with medications at all, just helping to guide her through, through this transition, and then to really talk about the options.
Well, what is a woman on this roller coaster experiencing? You've told us some of it. It's kind of like a PMS, unpredictable all the time. What else may she come in complaining to you or me or another physician about?
Yeah, so the physical symptoms, I mean, the classic are the hot flashes and night sweats. And that can be intermittent, and in perimenopause, it may be 2 weeks on and 3 weeks off. Later in the process, she might have some vaginal dryness. She might start to feel pain with intercourse or penetrative sex, and that becomes a growing issue over time. That often comes later in this process, but for some women, they experience it right at the front. Headaches, a lot of the classic symptoms of PMS. And as her sleep becomes more interrupted, she'll often start to see changes in her mood, her energy, her fatigue. I mean, this is the time when the body begins to change and sort of the way it manages energy. She starts to see a little change in where her adipose tissue, maybe the least
I definitely hear about that. Mm-hmm.
So all these changes are happening, and I think for a lot of women, it feels like they don't recognize this body that they've known for so long. And so I think it takes just education, and for some it's your calorie needs may change across menopause. It's it's not good news in that regard. But it's all can be managed, and there's good options for everyone. Even women who think they're not options for, there's good options. The verbiage has really gone from hormone replacement to now called MHT, or menopause hormone therapy.
MHT. I now I've learned something new
And
today.
that's right. So now we're not looking at replacement. We're really looking at what we call hormone therapy. And for a woman who has been who's had a hysterectomy in the past, she has the option of doing hormone therapy only with an estrogen, and that's what you'll see, ERT, or estrogen therapy. And it gets trickier now because for many women, they have a progestin IUD, and for those women, they have the option of not taking an oral progesterone, so they can just keep the Mirena IUD or the progestin IUD, and just take estrogen as their hormone therapy.
For me, it was challenging. I'll just share with my listeners. I went to Dr. Morris to handle my menopause that I didn't know. I was like, I've got to be in menopause. I guess when I first came, I was 53, I'm going to say. But I'd had a hysterectomy, and I didn't have any symptoms. I had no hot flashes. If anyone who knows me, I'm cold all the time. I sometimes go to bed with socks and long pajamas on. So no hot flashes. Brain fog. I mean, I don't know. I've got a lot going on. Definitely brain fog, cognitive decline, fat. I mean, I eat too much. That's why I was getting fat. So I didn't have any real big clue. Probably my staff say I was getting cranky. I have no idea. So we were just kind of randomly checking. And Dr. Morris clearly pointed out to me the issues about randomly checking levels. We could catch it at a good time, on the way down when it looks perfect, but until you catch it at the trough, or you're spending more time at the trough. And that's just kind of what we had to do, and tackled it. And then I carried on. But that was my personal scenario. And I've been an advocate of, I'm going to call it hormone replacement, but whatever, menopausal hormone therapy, we're going to call it now MHT, for my patients for years. And Dr. Morris has always been a really good resource because they say, go talk to your OBGYN, and then they come back and they say, well, I was like, did you talk to him about it? It wasn't much of a discussion. And I said, well, just, you can keep your OBGYN, but go see Dr. Morris for this talk and let him handle this. Can you tell us, because I think our listeners would want to know how you approach the woman going into menopause. And we'll just start with, let's just call the ideal candidate. Yeah, someone comes in and they are a number one ideal candidate. How do you approach that?
So let's say she's a dermatologist.
Very smart dermatologist, yes.
That's right. That's what I meant.
We're talking about Dr. McLean right now.
We mentioned the subject of, two things. One is I want to talk about the idea of hormone levels. So this is a sticking point for a lot of people, for patients, for physicians. It's okay to draw levels. You don't have to have levels. Sometimes levels can be helpful.
God, this is so liberating.
But you can't, especially in perimenopause, you can't take one level, which is one snapshot of one day, and think that you've been given insight into what's going on at the ovary. Remember, the ovary is releasing a new batch of eggs and follicles every month, and you may have some rock star follicles at age 50.
Pop out.
And your levels look perfect. It doesn't tell you anything at that moment. But at times, there are certain situations. If you have an IUD, if you have a hysterectomy, there's certain situations where those levels can be really helpful. I've had women come to me at 45. They asked their doctor for levels. They were told why they couldn't get them. We checked their levels, and they were in menopause. And those are the most important people that you really don't want to miss those women, because going into early menopause, they actually have increased cardiovascular risk. They have increased risk of osteoporosis. So there are plenty of times when levels may not be helpful, but there's times they're absolutely essential, and that's part of that shared decision-making and conversation with your physician.
Yeah, I think I was a stickler on checking levels because I just had no other clue
Right.
about what was going on.
And it's not, listen, we get metabolic, we get CBCs 50 times, and like one set of hormone levels isn't going to break the insurance system. It's like sometimes it's helpful. I think you just have to have a physician or a clinician who is willing to kind of have that discussion and walk you through what it's going to mean. The other thing I'd say is don't try and have this conversation between your breast exam and your pap smear. This is important. This is the biggest hormonal change a woman has secondary to puberty and pregnancy. So if you think that should be a 2-minute conversation, or your doctor thinks that's a 2-minute conversation, they're just wrong.
Yeah, I concur. I tell my patients, make an appointment just for this. This is the attention of that appointment. Make 2 appointments. Make a pap smear, breast exam, set up a mammogram appointment, but make another appointment for, I want to learn about what's going on.
Yeah, I ask this question all the time. They come in and they've sort of been trained, here's your annual exam, get all your questions out now because this is all you get. So when this comes up, and this is so much of the population I see now, that they come, they're due for an annual exam or they're due for a pap smear, and they ask the question, and we begin the conversation. And I generally say, listen, this is really important. This is going to determine your health over the next few decades. Will you come back in and we'll just have a conversation? We'll really dig into this and talk through it. And it's been pretty rare that anyone's not wanted to come and have that conversation. So
it's great.
I think it's okay to expect your provider to see you for a visit to do that. And I think increasingly that's what you see, that there's many more options out there for that. People are better educated. They're getting more exposure. If you talk about the things after the Women's Health Initiative that were criminal, most of the practicing OBGYNs right now had no teaching whatsoever for menopause. So these are the physicians in our community who had to go back separately and learn about this after they finished their training. They were taught one thing, and in fact, the Menopause Society itself said in like 2007 or 2008, we got it wrong. Like we said these things, we were wrong. We're going to try and correct this. And it took a long time. It really took until about 2017 when they released a hormone therapy statement that they said, we're wiping clean all the things we said, and we're going to try and fix this.
Wow, tall order.
It's taken a while.
Yeah.
So I think the conversation's important. Be willing to come back and have a visit solely devoted to that. And for a lot of providers, if they're not comfortable having that, there's resources for referral in our community. Our clinic, just to give you a sense of the demand, we have 5 doctors and now 3 nurse practitioners and PAs. 8 nurse practitioners and PAs, so 13 providers, and we are full all the time. So that's just gives you an idea of how needed this is as a resource.
Yeah, absolutely. If one of our listeners is an ideal candidate, what options does she have? If y'all have that talk, very good talk, and she's on board. And I think from what you've been telling me, more and more women are more readily on board than 10 years ago. What are the options that she has?
So it's a great question, and it is. Here's the good news: she has a whole array of options. She has. When I go into this, people are like, "I have no idea. This feels like I'm at a Denny's with a whole menu of things." So here are the basics. Most hormone therapy in 2025 is a combination of 17-beta estradiol or estradiol and micronized progesterone. So estradiol we typically give across the skin. So the one true side effect of oral estrogen, if you take estrogen by mouth, is it increases the risk of a blood clot. Now that risk is slight. It's the same risk you would have heard about when you talked about a birth control pill, but the risk, when we call the absolute risk, like what's the true risk, is very low, but that risk essentially disappears if she absorbs the estrogen across her skin. So she has the choice of a patch, there's multiple gels, there's a mist, there's a vaginal ring. So all of these are estradiol, and it really is what's going to work best for her. And sometimes that's a matter of insurance and what she has coverage for. But it's not expensive. It's another, if you're a pharmacy benefits manager, I'm sorry, I'm going to step on your toes purposefully. It is a pet peeve when women are being gouged for paying for these products when they're generic.
I think I'm getting gouged.
Yeah,
being honest.
The cash price for some of these is
It's not cheap.
$30 a month. The cash price for an estrogen pill for an estradiol pill is about 20 cents per pill. I mean, it's just nothing. So
I think I need to speak with my PBM.
so
Mine's not 30.
So that's right. So estradiol and then micronized progesterone is a capsule.
If they have a uterus.
If they have a uterus, although we use plenty of micronized progesterone in women who have had a hysterectomy, or if they have a progestin IUD, because of some of the effects of the progesterone are very helpful. Progesterone's an interesting drug. It does cross what we call the blood-brain barrier. It hits the GABA receptors in the brain. So the effect of the progesterone is it tends to induce some sleepiness. It tends to be promoting of relaxation. So we call it an anxiolytic.
Yeah.
So for many women, and not all, but for many women, they start taking progesterone in the evening, and anyone who does the medicine that I practice knows about 60% come back and say, "Oh my gosh, that was the best sleep. I haven't, my alarm woke me up. Like, it's been years since my alarm woke me up." And it is amazing in that it restores. I mean, sleep is this enormously important aspect of life that we need to be giving more attention to in these years, and we don't. And so that combination, taking away the vasomotor symptoms, the night sweats, the hot flashes, and a medication that is sleep enhancing, can be magical. Now, I should say that probably 10 to 20% of women just absolutely do not tolerate progesterone. So I want anyone who hears that to know if they feel sleepy, they feel groggy, they feel like they drank too much, they sometimes they have crazy nightmares. There's really about 20% of women who do not do well with micronized progesterone, and if you don't see a lot of this, it may be surprising because so many women do well, but there's definitely a population that doesn't tolerate it.
What do you do for those women?
So it's interesting. It can be a real challenge. So we start to look at some of these other alternatives. Mm-hmm. So there's a bunch of older medications that are estradiol tablets combined with what we call progestins. Mm-hmm. So these are I won't go into the details, but it's a synthetic form of progesterone, and it's in its own category. These are the products that you would have seen in a birth control pill. So things like norethindrone, drospirenone, those are all progestins. And so we generally combine the estradiol with a progestin first. And if she doesn't tolerate that, then we begin to talk about things like the progestin IUDs. Sort
of a special oral contraceptive pill then.
Or it is. It's a very low dose. So so this is, I think, an important point. The doses for hormone therapy are roughly 1/5 to 1/10 or even lower than what's in a birth control pill. So the reason we think about things like birth control pills in perimenopause is they are potent enough to suppress that crazy ovarian function. And sometimes you will not see the symptoms break until you suppress the ovary. But hormone therapy gets very low dose, and most hormone therapy is so low dose it cannot suppress the ovary. So the doses are much, much lower. But even then, these are the ones we have to continue to work through. There's one product that I think is amazing, and I could spend a whole podcast talking about it. It's called Duovy, and it's a combination of the old Premarin and a medication called basidoxifene. Basidoxifene is in a family of medicines that you've heard of. It's a sister drug to tamoxifen. So this medication can be used, the beta-doxepine can be used instead of progesterone, and it has a couple of amazing qualities. It's very bone positive, so it's in and of itself is a prevention for osteoporosis. But
That's a big plus.
There's growing
Real big
evidence
plus.
that it potentially reduces the risk of breast cancer. So you could be on a drug for hormone replacement that has good evidence that it's working against the risk of breast cancer, which is shocking for women to hear. And for women who have a high risk based on their family history, this drug is a great alternative for them to consider.
Because I know every patient that walks in your clinic is not the ideal candidate. and I see them, and I'm probably guilty of sending them to you as well. But I think every woman deserves that conversation. At least, even if Dr. Morris can't find a solution, you deserve to be heard and listened to. But what about, maybe this woman was taken off, and now she's well past that window.
Right.
What do you do about the older patient that's 10 plus years beyond menopause?
So once again, I'm going to not answer your question, but I promise I'm going to answer it.
I'm going to need a whiteboard to
keep me on
score
track.
you. Yeah. Uh-huh.
So I think it's important, and this is, we've talked about this, that the way I approach this is if you come and we're having a conversation about the symptoms you're having right now, you are suffering, you are having hot flashes, you're having night sweats, you're up at night, your sleep is disrupted, you're in the boardroom and your face is turning red because you have this explosion of heat. That you don't have to make a decision on whether you're going to take estrogen for the rest of your life. Right now, you're making a decision on how you're going to navigate this menopausal transition. And when we're on the other side of that, we will sit down and then we will talk about why would I take estrogen through my 50s and my 60s? Why, I've heard, like Mary Claire Haver obviously is out there. She's going to take her estrogen patch off, on her final day of life. I mean, it's...
That's when I'm going to stop coloring my hair, too, and getting Botox. She and I have a lot in common.
You don't have to make that decision on day one. Day one can be about navigating perimenopause into menopause, and you need to have a clinician that's a partner in doing that, and then begin to talk about those long-term benefits. I'm interested in my risk of osteoporosis. I have a family history of breast cancer. Some other reason that some doctors told me I'm not a good candidate for this. That's the time to begin having that conversation about the benefits of estrogen beyond the transition.
So what Dr. Morris is saying, if you're in the weeds right now, if you're hot flashing, brain fog, not knowing what's happening, there are solutions for you that are extremely manageable, navigable, and you don't need to make a life decision. Just go get help for those symptoms now, and then you can get down to the nitty-gritty. But what he's saying, this is a win-win. Get you through that.
I love that. I think I need a woman-splainer.
Do you want to go into partnership? I tried to get Dr. Morris to work for me a couple of years ago. It's like, this is the perfect combination, Dr. Morris. We have women that want to
say all these things that are going to sound all jumbled together, and then you'll be in like, what he's saying is,
don't waste that brain power.
Is woman-splaining a term?
What he's saying is, damn, girl, just get on it now. We'll have the tough conversation later.
That's right. So here's the part that's the challenge you've sort of led into, which is, if you go through the Menopause Society hormone statement, it has this line that it's safe to start within 10 years of menopause or by age 60. So that goes back to the way the data from the Women's Health Initiative was eventually looked at. So the safety and the benefits of estrogen therapy were really isolated in this decade of women between 50 and 59. The data from the WHI was broken down into those segments.
But the WHI was mostly older women, right?
It was. The average age was 63. The women were well into their 70s, I think even the early 80s. So, and that's important. I mean, keep in mind, this was not, there's even people who talk about if you're having terrible vasomotor symptoms, maybe you weren't put in the study because people thought you would you would drop your placebo and take estrogen. That
Oh, that's right.
it really was not.
Yes. That's not randomized. They're like, oh, you're symptomatic.
Oh, that's
You're-
just stories.
Yeah.
And
Oh, it's conspiracy. Let's go.
oh, I won't. In the 80s, there was a study called the Nurses' House Study, and nurses are so diligent. They filled out this paperwork year after year, and it looked like the women who took estrogen well into their 50s and 60s and 70s had a lower risk of heart disease. And one of many fumbles we've made in medicine, in the 90s, women were being started on estrogen to quote unquote prevent heart disease. And in fact, some women were given estrogen because of their heart disease with no evidence other than this longitudinal, retrospective study. And so good clinicians said, this is not good practice. We have no idea if this is good. And so they went and they got $1 billion, which in the early 90s was a ton of money.
Yeah,
No,
it's not now. It sounds like a lot. It's not now.
It took a lot of work. And the study, its primary objective was to determine the risk of heart disease or the outcomes of heart disease and estrogen. So all of these other findings, osteoporosis, fracture, colon cancer, diabetes, all of those were secondary outcomes. The study was not designed to look at that. It was designed to have a balance on the risk of heart disease. So when the results came out, and this took years, I mean, they had the press conference in 2002, but it took years to actually get this data right. They eventually broke that data into decades of life, 50 to 59, 60 to 69, and 70 to 79. And you really saw most of the benefits, and the benefits being cardiovascular risk, osteoporosis and risk of fracture, colon cancer, insulin resistance. Those were really isolated for women in their 50s. And for women in their 60s and 70s, you actually saw an increased risk of things like stroke and cardiovascular events. So when the Menopause Society, and keep in mind, there's no studies that, I mean, when you put the Women's Health Initiative next to other studies, it's got so many more people. It's a placebo-controlled trial. So it's like a gorilla. You can't do these, what we call a meta-analysis, because the WHI just weighs down the data. But that's where the Menopause Society is a conservative organization. They stick very closely to the data they have, and that data is mainly from the WHI. So this is one of those occasions where we love to trash this study, but it is some of the best data that we have, even supporting the use of estrogen. What happens when she's 61 and she comes in and she says, my friends are on this, they feel better. I was told, this is what I was told. I wish I had done it, but here I am now, and I want to talk about this. And so what she really deserves is a good conversation. She's not a data point. She is a human being who can think for herself and make decisions. So it doesn't mean she can't have estrogen because she's past the age of 60. It means she needs a good risk assessment. I may send her to a cardiologist for screening. I may send her for a coronary calcium score. We're going to get all the information we can, and then we're going to talk about what formulation might be safe if she wants to try it. And that's where when you move from these oral estrogens to the estrogens across the skin or transdermal, you see a lot of these cardiovascular events. The risk diminishes, although we don't have great data on this, but if you're going to go the safest route, that's something that if they have a clear cardiovascular screen, we're going to talk about the option for her.
What if she's got a little evidence of some plaque buildup?
Then that's the part of shared decision making, but I don't think that's restrictive. It just means she needs to know that she's taking some risk, and I think it's also a good time to really understand what she wants and what she's looking to get. So, I'm going to make a shameless plug about vaginal estradiol.
Yes.
That for so many women, that's become such a problem that no one's helped them. So now...
Problem, sex, comfort.
I mean, for some...
general urinary stress and
all
incontinence.
Of the above.
All the above.
So urinary tract symptoms, chronic dryness, chronic burning, urgency to go to the bathroom, up at night, diminished sexual function, vaginal, I mean, it just goes
I mean,
on
this
and
is
on.
health, wellness,
So-
social, your interactions with your spouse. It's just so important.
It's hugely important. And it's important because the risk for women in their 70s and 80s coming into the ER with urosepsis.
My listeners know this because they're taking care of their older mom.
That's right. I mean,
And
this-
their heart falls in their stomach when they hear your mom's is in the emergency room with suspected UTI.
So
It just goes bad.
it's- I talk about this all the time, and I say these things like, a UTI in a 75-year-old is not a benign event. I mean, for a lot of those women, they have mental status changes. And I say this to my patients, and they're like, you have no idea how many times I've had to take my mom to the ER. And so that is preventable with topical vaginal estrogen. It benefits the vagina, it benefits the urethra and the lower part of the bladder. It can clear so many of those symptoms. And as of this year, in the 2025 urology guidelines, the AUA guidelines recommend as first-line prevention the use of vaginal estrogen.
It's amazing.
And so some of these patients at 60, that's really what's bothering them the most, that they've lost the ability to have pleasurable, comfortable sex. And when we talk about you can do this essentially with zero risk, this is one of the occasions, the societies I belong to, we have been fighting for years to get this black box warning. I mean, if you have not listened.
The audience, a black box warning is when you go and you pick up your prescription and you got those like 18 pages of wasted paper. There's some talk about getting rid of some of that because you want to talk about inefficiencies. But at the top, it's a black box. And I believe pharmacists point that out.
Yep.
Like, hey, here's
the
your
black box
prescription.
warning.
Congratulations. Comes with a black box.
So
door prize.
it leaves this impression
Yeah,
that
it's
if you want to
terrifying.
have pleasurable, wonderful sex, oh, by the way, there's a risk of heart attack, stroke, and cancer. I mean, how awful.
Right. Then this woman feels guilty. Do I want sex that much?
And
but
no
then
one's standing at the pharmacy saying, oh, by the way, none of that's true. That big warning has never been proven.
You need Dr. Morris on your shoulder. Maybe, Dr. Morris, what you could do is just let them record something on your phone, on their phone. Say, give me your phone.
If you
and
do
what you do is
anything,
Dr. Morris says, ignore the black box
I
warning.
actually
This is
write this in my
completely
charting. I've told, ignore the black box warning. It is not true.
We're going to have to modernize
So-
you. You got to get electronic with this. Or maybe we could do a little video.
write
Kristen,
it.
at the end, we'll just give a little video.
I think the hero of this right now is Rachel Rubin, who, if you've not heard her on a podcast or seen her YouTube channel, she's amazing. She's a proactive women's urologist, and she makes this case. And I mean, she is amazing and fantastic and so much better at it than I am. Go find her, listen to one podcast. She spoke with a group of experts to the FDA probably 3 months ago.
And she's a surgeon.
She's a surgeon.
Right. And so she's making women's lives better through surgery. Here's a surgeon saying, look, this cream can
change
maybe
everything.
even better than me.
It's good for your vagina. It's good for your clitoris. It's good for your sex life. It's good for your bladder. Oh, and by the way, there are no risks.
Well, this is a drop the mic moment, but we're not going to drop here because we're really on a roll.
So that's part of every woman should be with a clinician who is willing to engage. For us, talking about sex is like talking about swallowing or talking about running. I mean, it's part of what we do. And I'm going to ask the question: Are there issues? Are you finding that your interest and desire is less? Are you able to respond normally? Is it uncomfortable? Is it painful? And for so many women, it just doesn't feel right, and then it becomes painful, and then it just becomes something, that they wish they could X out. It's horrific because it's all fixable, and it's better to be preventive. So all the time people say like, well, I'm doing okay, and I say, well, don't wait until that tissue changes and then you're in a rescue moment. Like it is smart to be empiric and do this ahead of the game. And, you're going to be out with friends, out for a glass of wine when you're in your late 50s and be like, that never happened to me because I was on it. My physician told me.
Listeners, in their 50s now. What he's saying is you can do your daughters a big favor by getting on this, and then you will save her the heartbreak of you going into sepsis when you're 75 just because of a simple UTI.
And you'll change the dynamic that this is expected. It's expected that you're going to take care of this, and options are going to be available. And a tube, can I make a shameless plug?
Shameless plug, here we come.
I step on the PBMs again. For a lot of my patients, I'll send them to Mark Cuban Cost Plus Drugs. Oh. If you really want to see what medications cost, go to Cost Plus Drugs and look up, because they have a standard set pricing of what they increase over their cost. So a tube of estrogen is about $13. So if your pharmacy or your insurance is asking you to pay $60 for this tube, it costs them probably $10.
Wow. Huh. That's good to know.
Oh, there's no reason, cost included, that this shouldn't be a good option.
And that's called estrogen cream or vaginal cream?
So estradiol cream. There's a Premarin cream, which is the old conjugated equine estrogens, the old Premarin. Yes, it came from
horse mare.
From
they dump
pregnant
estrogen
mares
in their urine when they're pregnant.
by the ton.
And by the ton.
Which
gross ton.
This is a very interesting topic because estradiol, which is made mostly from soybeans, is very different than equine estrogen. So the Premarin pill and the Premarin cream is different than just estradiol. This is the nitty-gritty stuff.
Yes.
So the patch, the mist, the ring. And so there's both of those creams available, but there's also a vaginal insert. There's a tablet insert, and then there's a little insert called Imvexi, which is it's shaped like a teardrop shape. So people are like, the cream goes everywhere, or some people don't like the tablet insert because it's literally it's like 90% of a plastic applicator, and so this little Imvexi insert is great. There's a ring called S-string, which can be inserted for 3 months at a time. So there's some great options out there. All of those other ones are delivery of estradiol, so a plant-based estrogen, and what people call bioidentical estrogen,
yes,
which is estradiol.
So we've heard benefits getting you through this god-awful perimenopausal hot flashes, and we've kind of flashed forward to the 60-plus-year-old woman that can help her with her sex life and make the tissue healthier from a genitourinary standpoint.
Right.
For the woman who's gone through the perimenopause and she's come back and she said, well, Dr. Morris, I'm all better and I'm now 54. I mean, surely I'm not going to have any more hot flashes. Why should I stay on estrogen? What benefits do you tell her about?
Yeah, so that's the next phase of the conversation. And now she's really, so I turned that into, let's think about your health over the next decade or 2 decades. And so it's not just about hormones. This is about what you need to be thinking about. And so it's a broad conversation, but from the standpoint of the hormone therapy, I think the number one is always bone health. So going back to the Women's Health Initiative, that study proved something that had not been seen previously. It's the only study that I'm aware of for women in their 50s that showed a decreased risk of fracture, whether you had osteoporosis or not.
I could tell my women listeners here, this is big.
If you are
but they know it. They are worried about osteoporosis. Many women are worried.
So this is, and again, this is more than hormones. This is more than estrogen. So I will add to that. There's osteopenia, loss of bone, and sarcopenia. So
loss of muscle.
And you may break a bone. So most hip fractures happen in people who are not osteoporotic. The majority.
Gracious, that is news to me.
So you have to think, why do people fall? They fall because they lose
their
muscle
core
mass,
strength.
they lose their core strength, they lose their balance.
Yep.
So bone density, what determines whether you have osteoporosis, it's not bone strength.
Interesting.
It's one measure of bone. It's used to predict who is at risk of fracture. That's all it is. So your goal should not be to have better bone density. Your goal should be to have strong bones. And to get strong bones, you need good intake of calcium.
I've been told. I'll plug.
And-
I'll plug
and
for
it
Summit
doesn't-
Coffee here because Dr. Moore, I am addicted to this latte. There's something magical. I just
is
came
pretty
back
magical.
from Italy. Italy. This is the best latte. I'm going to accuse them of putting something in it that has made me addicted. But yes, Dr. Morris.
That's why they open across the street from
Correct.
me. So.
Dr. Morris fussed at me, although I told him there's nothing to worry about. He asked me, how many push-ups can I do? And I was like, oh, I don't know. I'm sure some, right? I can do north of 10. It's okay. I can do. I assured him, and I'd lost weight. He's like, no.
Yep.
Sarcopenia. And I'm like, no, I'm strong. I ride a horse. I can water ski. And I am strong. And I'm hearing it from my patients too. We are adding strength training to our regimens. And I've try to add dynamic movement. Anyone who walks by my house in the early morning, you may see me slinging myself over a step. I bought one of those like step aerobics, but that dynamic, unpredictable movement teaches first of all, your muscle to hold you into place, and then it strengthens
and it puts a
the
stress
bone.
on your bones.
Correct.
And I'm not a bone specialist, but this is important stuff. That
More so than just jogging.
jogging actually does very little.
Correct, because it's the same movement.
And swimming is a great exercise, doing nothing for your bone health.
So we could do a virtual Charlotte Skin and Laser step aerobic class in the morning. Maybe I'll just start a viral.
I bet your skin looks great when those
we
step
can
aerobics.
all just sling ourselves over this step. I have to watch the
I'm
dogs.
so proud of you.
though.
I didn't know. Now
Oh,
I'm
absolutely.
going to put it in your chart today.
Yeah, step aerobics.
Electronically, I'm not going to write it. So if you want the ingredients for healthy bones, it starts with
Get the pencils.
good nutritional calcium intake. Don't think that all this should all come from one big calcium tablet. That is not the way to think about this. So if you're going to supplement, you can do a reasonable vitamin D supplement, calcium as a part of your nutrition. The goal to get 1,200 milligrams a day, and really try and get it and divide it.
And that's a lot because, I mean, look at your labels. It's a lot.
It is, but if you get it at 200 or 300 at each meal, and then a multivitamin, you're not getting benefit beyond that 1,200.
I'm just going to have to start adding milk to my bourbon at night, and then I'll be right there. I'll be right on top. Yeah.
The latte's got plenty.
It does. I'm sold. I'm in.
So, and then the other ingredient is putting stress on your bones. And
tennis players, I hate you for your sun damage, and I fear for you. Wear your shirts. But you are doing a grand service for your bones. It's phenomenal.
So that demand drives bone turnover, and it's that turnover, what bone naturally does. It breaks down and it rebuilds. Putting stress on your bones is a huge difference. And
Brilliant.
There's a
basketball too, but I don't know many middle-aged women that play basketball.
If you look at there's a study out of Australia called the Lift More trial, and I think it's really changed the dynamic. This is 80 and 90-year-olds being guided in very heavy resistance training. So deadlifting, dead hangs. And
I'd love to see that class. That's awesome.
It's on YouTube.
Okay.
And so you can go and actually watch them. And
it might shame me into lifting bigger weights.
They have MRI data showing that their bone starts to remodel in response. So
Amazing.
You can, if you're idle for 15 years and you start strength training, you will see a difference in your bone health with near immediately. So
this is great information.
You take all of that and now add in some estrogen across your 50s. You're going to maintain your bone health. In all likelihood, you may, when everyone else is seeing their bone density drop, yours is going to be flat or maybe even elevate. And that's the benefit, is you're going to go into your 60s with optimal bone health and hopefully optimal muscle health that you've started to do resistance training. And your risk of a fracture, not all fractures can be avoided, but your risk will have gone down dramatically by doing that.
Yeah, because we're going to see some decline as we age, so come in strong.
This generation is incredibly healthy. They're attentive. They're,
this generation, our peers?
Our generation.
'Cause
The-
we might have some younger listeners, Dr. Morris.
The red dress campaign didn't exist many years ago. So women are aware of heart disease. They're really looking.
What's the number one killer of women, Dr. Morris? Heart disease.
That's right. So I think, and I say this all the time, gosh, you're super healthy. You're taking great care of yourself, and you need to worry about your bones because you're going to live a long time. If you're healthy in your 50s, you're probably going to live to 90 to 100. It's a long time for your bones to be with you. So you've got to start thinking about them because for women in their 40s, they see their friends, they hear about friends with breast cancer, and it's really scary. For women in their 70s, they see what happens after a hip fracture. They see that their neighbor doesn't come home from the hospital or it goes to long-term care, and that becomes a real fear. And that's really hard to turn around when you're at 60 or 70. So that's the moment in time where we're talking about what can you do now? And estrogen is an integral part of that conversation.
Bone, heart. It's great for preventing heart disease. I don't think that's a real fear, and I think it's mostly many women don't understand the number one killer of women over decades, young decades too, is heart disease. So every time I see a pink fire truck, it actually, sorry, pink ribbon wearers, it actually annoys me. Just keep it red.
Yeah.
Because it's cardiac disease. But I don't think that's a big fear.
We've made enormous strides. I mean, to think what's happened in breast cancer and and
tell our listeners, just average, these are average numbers, what the survival rate of breast cancer is.
Especially early stage breast cancer, which most are now diagnosed early stage, the survival is well over 90%.
Yeah, over 90%.
So for a woman who has breast cancer, the most likely thing she'll die from is heart disease.
Wow.
So everybody needs to be thinking about this.
I think a big fear among women, this is why you see the Sudoku and the Wordle, I'm keeping smart, doing crossword words, is cognitive decline, development of Alzheimer's. Women get Alzheimer's at a rate much higher than men. Men have different neurodegenerative disorders, but the big neurodegenerative disease, you can be as healthy as you want, but if you're declining up here, what is there good evidence, or what evidence is there about the role of estrogen in that?
Yeah, it's what I kind of rank third as part of that discussion, and so if you're waiting for that study, the prospective trial looking for estrogen versus placebo and the risk of cognitive decline or Alzheimer's or dementia, it's never going to come. There's no way to start someone on a medication in their 50s and look for outcomes in their 80s and 90s. So all of the data is going to be, it's just going to be retrospective. It's going to be starting with women dementia and looking backwards. So there's never going to be great data on this. I will say this, the data that's out there really supports starting early. And that's
in perimenopause.
Perimenopause into menopause is really
during
the time.
That roller coaster time.
It really is.
Yeah.
I mean, so most of the bone loss that occurs by the time this gets into kind of the really detailed stuff that we are looking at. Most of the bone loss has happened by the time she is told she's menopausal.
Good gracious.
So that's one of these things that, when we say women have been misled, and frankly, their doctors, their providers weren't taught this, that when you come in and you say, it's been a year, or it's been a year and a half or 2 years on my
no period.
That's right. And you've already reached the point where there's been a big loss. So there's bone loss from your 30s. From the time you're in your 30s, you're losing a little bit of bone every year over time.
You're also losing collagen, listeners. Let's keep that as a common theme. This is Queen City Skin. Man, those 30s.
I know. And so in your late 40s, early 50s, when you're in that transition, there's a sharp drop in bone density, and then it plateaus again back to a more flat, ongoing loss, but not this precipitous drop. I think the perception always been that happens after menopause. It really happens earlier.
Yes.
So
That was my perception, and I bet a lot of our listeners will agree.
yeah, if there's one thing that I have changed practice, that I really look for reasons, especially if you have a family history, and ask the question. Ask the question. All the time people will say, "Anybody have a hip fracture?" And the answer is no. Then you say, did anybody kind of have that curve in their spine? And like, oh my gosh, my mom's sister had this, terrible curve. Mm-hmm. She had osteoporosis. You need a DEXA scan. You need an early DEXA scan. And it has been an enormous shift that in doing that screening, sending women for DEXA scan, finding women who really have a low bone density at 48, 49, and now that conversation shifts. Now they get it. And they realize that they're at risk, and they are ready to look at this conversation differently.
So we've got heart, bone, cognition. I'll throw in skin.
Yeah.
It really does help skin.
So I don't know that we know a lot about it. We know that it changes collagen production.
It is not even, it's just kind of like the cognition. It's not been looked at.
Right.
But men and women age similarly up until menopause. Postmenopausal women, uncorrected, dive off the cliff with aging changes. And some of that's bone and structure loss, sarcopenia, loss of muscle, shifting fat. But skin-wise, they just age way more. That might be the extent of our knowledge. Mm-hmm. I do recommend a skincare product called Imapel that activates or stimulates an estrogen receptor in your skin. But we think that estrogen may play a role in something new called DWAT, dermal white adipose tissue. It's all kind of new. We're boldly going into this regenerative medicine field. But as I'm seeing patients cosmetically, well, let's just say we do a filler session. I'm spending time with patients. We're doing an intense consultation, and I find out about their sleep. Sometimes it's real obvious. Their stress, their masseter is out to here. Mm-hmm. Sleep, stress. I hear about mid-weight gain, mm-hmm. and I encourage all my patients to look into hormone replacement for that reason. Hair is another one. I think with that declining estrogen, you get an androgen predominance, just as kind of a dominant factor,
Look at you. That's exactly right.
Exactly. So estrogen's going down. Those androgens are more prominent than this kind of hair thinning up here. So I said I got really interested in treating hair, not only because of cancer patients, because it just devastates me to see a young woman who has the hair like a man, and because this is her life. I mean, okay, you've cured her cancer, but she's got her life to live. But I take care of patients over a long lifetime from when they're just vibrant, 40-something years old. My peers, I started this a long time ago. Maybe a lot of my patients are 10 years, 12 years older than me, so I've seen them. And we take photos, and I start looking at them like, you're thinning. It's a horrible conversation to have, but it's one that needs to be had because it's vital to how they look and feel. But, as I've gone through this with women, I have for years, and a lot of times it was a harder argument. As I was telling Dr. Morris, we might be seeing different patients. He is seeing patients come to him because they know they've got the word, and I want to have that conversation. Me, I am seeing the patient in my chair having a hot flash and complaining about midweight and complaining about, I go in the pantry and I forgot why I was here. So I'm talking to them. I was like, you need to talk about hormone replacement. But I got to change that to menopause hormonal therapy, MHT.
We don't know if it's going to stick.
We're going to try. I'm going to try to help you.
Well,
maybe we could do stickers.
You're far from even in the whole menopause society. It's even at the national meeting, people
you need a cheerleader.
Don't get it right.
You need a PR campaign.
I think hormone therapy is.
Yeah.
So
what I get is, I'm high risk for breast cancer, or something like that. So I'm kind of seeing a different skewed population. Certainly, I know for both of us, that conversation was a heck of a lot different. We'll just say pre-COVID, 6 years ago. The fear of the breast cancer
Right.
was way up here.
So this is one of those myths that needs to be busted.
All right,
So-
let's bust it. Myth, but
so
where's our
let's go back to the value that was in the WHI.
Mm-hmm.
So the women were in two categories: those who'd had a hysterectomy and those who had not. The women who had had a hysterectomy got only estrogen. The product they got was called conjugated equine estrogens,
yes, and
or
they did
Premarin.
not get progestin.
They did not get a progestin. Though that study, the part of the study that was women who had a uterus who got an estrogen with a progestin, that was the one that stopped after 4 years. The estrogen alone arm did not stop. It went on for 7 years. And the risk of breast cancer in those women receiving estrogen for 7 years was actually lower in the estrogen group. That group of women has been followed for an additional 20 years. Joanne Manson, who's a wonderful researcher, has followed all these women all of these years. And in 2022, they found that for those women who took estrogen, their risk was even lower 20 years later. So that is black and white.
That's pretty black and white.
Women who took estrogen in the Women's Health Initiative
And
had a
stayed
lower,
on estrogen.
and for 7 years. After 7 years, they were released from the study. So,
Okay.
but in that group that took estrogen, the risk of breast cancer went down. So this whole idea of estrogen causing breast cancer, that alone should dispel that. In the biggest study, the largest trial we've ever done, estrogen by itself lowered the risk of breast cancer minimally at 7 years, but what we call statistically significant at 20 years later.
That's amazing.
So you're right. It's a different, and it should be a nuanced conversation. It's a different conversation if she is not going to take any form of progestin or progesterone. I think those women have sort of this advantage that the greatest benefits were seen in that group.
Estrogen only. So in the modern age, that means no uterus.
It does, although
there's some new medicines coming
that's right.
out.
We
Yeah.
really like my partners and I have been
estrogen?
joking we need a perimenopause pill because it's really hard to navigate through. But we really like using one of the progestin IEDs because this perception of, oh yeah, I can't get pregnant. I mean, your risk of pregnancy is low, but it's not zero. So it takes care of bleeding, it takes care of that irregular bleeding. It actually reduces the risk of uterine cancer, and it protects the uterus while you're on estrogen. And so you can basically take your bleeding out of the equation, and then you become like an estrogen-only patient. So it should be said that
With a lower risk.
I think that's some
cancer.
of the lowest risk is. I love using those IEDs, and I think anyone who does this type of care feels that way. It gets talked
We're
about a lot.
talking risk, not guarantee.
That's right.
Everything
And-
is relative.
And these are things that unless you do this, unless you're an OBGYN, you may not know this. If you look at the amount of the hormone from a progestin IED that gets absorbed, it's 1,000 times less than a birth control pill.
Good gracious.
It's a tiny fraction. So people have this perception you're going to put this IED in and I'm going
Yeah.
to have a bunch of hormone. It is, and that's directly from the product insert. It is an order of magnitude less. It's barely measurable. So you're really not getting significant hormone in your bloodstream. It really, to me, it's almost like you're being treated as if you don't have a uterus because the IED is doing that protection.
What about a woman that said, I'm sold. This sounds great, but I'm not going to wait for that roller coaster. I'm
Yep.
going to come in. What do you tell that woman that's just like, she's come in, she wants to get on top of it. Sounds to me like she probably doesn't need it at that point.
Well,
What advice do you give her if she's coming in real early?
yeah, it starts with that conversation. And I think it starts with women are intelligent. They know their bodies better than anyone. And what they may not know is some of the physiology beneath those changes. And so I think it starts with a discussion. Let's talk about why you're feeling the way you're feeling. Let's talk about what's happening. And this idea that you're in a state of estrogen deficiency is probably false. Some may say, prove it. Like, I'm not opposed to getting a level at that point, and we'll talk about what that means. And then talk about what the choices are now and what that may look like later. But listen, if I start a woman on a birth control pill, it's markedly more hormone. I mean, we have women in their 40s on birth control pills all the time. Mm-hmm. So it's okay if you decide to do a trial of transdermal estradiol and micronized progesterone. More and more women are trying this early, and some women feel amazing. And it's just the trial and error of hormone therapy. And it's not going to work for everyone. And I kind of put that out there early. But this is low risk stuff. You're not jumping to a deep end with a bunch of sharks. This is literally 10x lower than a birth control pill. Mm-hmm. So it's not high risk. And in fact, if you do great on it, then I think it's important to say that it's not contraceptive. So you still need to know that pregnancy is a possibility. So taking these hormones isn't going to prevent that. So that needs to be considered. But I don't have a lot of safety concerns for treating women in their mid to late 40s, as long as they know, that they're not the Philharmonic. They're now the middle school band, and these aren't
got some squeaky horns in there.
Right. These aren't necessarily estrogen deficiency. It's oftentimes the wide swings up and down.
This might get you in trouble with your family. Did you sit through middle school band concerts? You might be in
plenty.
trouble now.
And they listen. They would be fully supportive, and
yes,
they had to sit through each other's concerts.
Oh, so. God bless them. God bless them. Well, we've talked, a lot of information here, and I think very helpful information.
And thank you. This is, I know this is not your typical.
No, but I think it's valuable, and I would venture this is going to be a high ranked podcast because of the level of interest. And so we've answered some simple questions. We've taken a deep dive. We've answered questions that maybe are in women's minds, but they can't quite formulate it, like just this harboring fear. We've learned the advantages. I've learned things, listeners, so I know you have learned things. It's been phenomenal. The estrogen cream. One thing I should mention, the estrogen cream, there's all this stuff online about putting estrogen creams all over your face. Just keep in mind, it's not been studied. Anecdotally, I have heard of some of my colleagues enjoying it just around the eye. And that's a thin skin area, so you'll get some penetration and some improvement. I don't personally use it. I keep meaning to try it just because people ask me. But I don't advocate for smearing it all over. You will get some absorption through your skin. Your skin does allow blood absorption, so we want to be careful and cautious of that. And there's no studies that I can tell you about to guide patients. So number one. Number two, there's so many great skincare products that we know and we have proven via in vitro studies, meaning in a cell culture, but also in people, is very effective. So we don't need to go reaching and making up strategies. So maybe my homework assignment is I'll try a little around my eyes. Unfortunately, I've started using the exosome plated around my eye, and I'm addicted. So I don't know that I'm going to let that go.
I think it should be said, exactly what you said. Especially for someone who's beyond menopause, no longer having menstrual cycles, we don't know if this is absorbing or not, but it very likely could give you a low systemic level. And if you're getting a low systemic level, that may affect the uterine lining. So that is a potential concern, and you need to, people are buying these creams everywhere. You need to talk to your physician and say that you're using this. I'm the last person that's going to say, don't, if it's helping you, stop. But you just need to know that may need to be something you watch for and proactively manage. We just don't know at this point.
Exactly.
I would also say if you're doing that, but you're not putting on, your cream with sunscreen in the morning, you're
Oh,
not.
I put on everything. Are you kidding me? I've already told the listeners about this panel I was on with like 6 other women about what's on your bathroom shelf. I'm like, dear God, each of us could talk an hour, but we had to narrow it. But if you were to summarize for our listeners, what's the best learning point in all this? I think for me, I've learned a lot. But we heard time and time again from Dr. Morris that a woman needs to be heard and she needs to have that conversation. And the physician is a little back and forth about where she is, what her risks are, where's the lifestyle. And I think that's the most valuable lesson. And I hope you got some science out of this too. But what would you say in summary, Dr. Morris?
Yeah, I think this concept of shared decision making is paramount. That you feel like you have a partner, you feel like you have somebody you can trust, that you can talk about hard things, intimate things that can help guide you through these changes. If your pediatrician said, "Oh, we'll only talk about puberty once for 2 minutes," you would be like, "That's crazy. I'm going to take my kid somewhere else." So if you're in the midst of this change and you're not getting a good conversation, you need to seek that out. And there's a growing number of people in this community who are available, who have either been doing this for some time or are really getting up to speed and getting great education. I saw more physicians from Charlotte than I ever seen at the menopause meeting, and I think it's amazing. This is not a competition. We're all supporting each other and hopefully starting to support this community. I think the other thing I'd say is that you need to seek out the people online. When I see patients, I say, I'm going to send you to podcasts and people who teach me, the people I've been seeing teach for years. We talked about Rachel Rubin in urology. For patients who've had breast cancer or worried about breast cancer, there's a physician named Corinne Min. She's had breast cancer. She had it in her residency. She's amazing. What a great resource for women who are going through that experience and thinking about hormone therapy. Avram Blooming, if you want to hear about the history of this, there's so many good resources. Don't take that one podcast, dig deeper, and hopefully your clinician can guide you on where to get that education.
Well, that sounds terrific. I think after listening to this, everyone can understand why Dr. Christopher Morris is so beloved in our community. And I don't have an audience here, but I'd give him a big applause.
It is. I've been here for 25 years, and the gift to me is I have been able to take care of my patients and women in this community, through hard pregnancies, through miscarriages, pregnancy losses, changes in their lives. I've been through their weddings. I mean, the best part about being in OBGYN to me is that you get to go through these chapters, and I've had this wonderful group of patients who's been with me for a long time, and it's such an honor. It makes my day. Some days are hard, and I go into a room and it's like seeing an old friend. So I think the women in this community are amazing, and it's just been an honor to take care of them.
That's amazing. Well, thank you so much for joining us.
Having me.
And thank you all for listening to this episode of Queen City Podcast.
Thanks for listening to Queen City Skin with Dr. Elizabeth Rostan and Dr. Emily McLean.
We hope you're walking away with tips and insights you can trust, and maybe a little extra confidence too.
If you enjoyed today's episode, be sure to follow or subscribe so you never miss a dose of skincare wisdom.
And if you have questions you'd like us to cover, connect with us at Charlotte Skin and Laser or find us on Instagram at Charlotte Skin and Laser.
Here's to healthy skin and feeling your best. We'll see you next time.